Welcome to the Ventilator and Pulmonary Mechanics Chalk Talk series, where we're learning how ventilators work and how to work with ventilators. I'm John McManigal. Let's get started. Last time, we took a good look at the clinical advantages and disadvantages of pressure control and volume control modes. We decided that pressure control, with its lower peak pressure and higher mean airway pressure for a given tidal volume, is better for oxygenation and patient comfort, but at the expense of the stable minute ventilation that defines volume control mode. This time, we're going to look at some of the more modern ventilator modes and how they work to get the best of both worlds. These newer modes are ramped volume control, pressure-regulated volume control, and volume-assured pressure support. We call these conventional ventilator modes because they mimic a natural breath cycle. There's a defined inspiratory and expiratory phase. There are some unconventional modes, like airway pressure release ventilation, or APRV, and high-frequency oscillation, that are used in more desperate attempts at air exchange in severe pulmonary pathology, and we'll set those aside for now. Even though it's an interactive mode, which in general we're saving until the next lecture, we'll talk about volume-assured pressure support this time because its fundamental goal is to get at that best-of-both-worlds scenario between pressure control and volume control. So let's get started. Probably the most straightforward way to combine the benefits of pressure control and volume control, we'll draw over on the left side of the screen, is called ramped volume control. This is still a flow-limited ventilator mode, so we'll start drawing down on our flow graph. Just like always, we'll start at zero flow at end expiration. The strategy of ramped volume control is to limit your inspiration by flow, but to simulate the waveform that results when you limit by pressure. So instead of using the constant flow of traditional volume control, ramped volume control intentionally begins with a higher flow limit, and over the course of the breath decreases the flow limit, generally in a linear decline, before stopping the inspiration. So what does this look like on the pressure graph? Circuit pressure and pulmonary pressure begin at PEEP, just like they always do. To force this initial flow into the patient, the circuit pressure rises to some relatively larger amount higher than the pulmonary pressure. And as the pulmonary pressure rises, the programmed volume flow rate decreases, so the required delta between the circuit pressure and the pulmonary pressure also decreases. This doesn't give a completely flat pressure curve like pressure control does, because there's still some relationship between the pulmonary pressure and the circuit pressure that's being maintained. Again, the limit variable that's fixed is the flow value, and in this case the shape of the flow curve. But the pressure curve is quite a bit flatter than it would have been in traditional volume control mode. Just like all of our modes, when it's time to cycle to expiration, the circuit pressure drops down to PEEP, and expiration proceeds just like in every other situation we've looked at so far. The advantage here is that with an inspiratory flow that ramps down, and therefore a much more flat circuit pressure curve, we gain the advantages of pressure control in terms of patient comfort, lower peak pressure, and higher mean airway pressure. And, just like in volume control, you as the operator are still setting this tidal volume, which is the area under the flow curve. So in the event that your respiratory mechanics change, your ventilator will still maintain a constant tidal volume and minute ventilation. The other advantage is one of flexibility. If you do have a patient with high resistance and you're worried about the peak airway flow, you can change the slope of the ramp shape to be whatever you'd like. So in these ramped volume control modes, you can set on the ventilator whether you'd like a very flat ramp or a very steep ramp. The other general way to approach the best of both worlds question is with pressure-regulated volume control. This mode, despite the volume control name, is actually a pressure-limited mode. So let's look at how pressure-regulated volume control, which you'll also hear called pressure control with volume guarantee, works. Because it's a pressure-limited mode, we'll start by drawing on the pressure graph. We start with circuit pressure and pulmonary pressure, both at PEEP at end expiration. This mode will give a normal pressure control breath at some inspiratory pressure, and just like normal, the pulmonary pressure will increase, and that's going to give us our normal pressure control inspiratory flow and expiratory flow. But what makes this mode so useful and different is that this is one of those servo modes that we hinted at last time. Even though the limit variable that defines the breath is the inspiratory pressure, after every breath, the ventilator computer is going to go back and look at what tidal volume it got by looking at the area under the flow curve. And if the tidal volume was a little bit low, the computer is going to increase its own inspiratory pressure for the next breath. And so that next breath is going to have a higher inspiratory pressure and therefore higher flow rate and higher tidal volume. So in this ventilator mode, your ventilator computer is constantly monitoring the tidal volume, and it will automatically change the inspiratory pressure as appropriate. So it is a pressure limited mode because the pressure is what defines the valve behavior during inspiration, but the variable that you set as the operator is the tidal volume, which is why they give it the name volume control. So both ramped volume control and pressure regulated volume control have the advantages that their shapes look like a pressure control mode, meaning less potential for barotrauma, a little bit better oxygenation, but they will both maintain a target tidal volume, removing the risk of changing minute ventilation when compliance changes. So let's work through this with two examples on each mode. First, we'll look at an acute decrease in compliance, and second, we'll look at what happens if the patient coughs during inspiration. We'll start in our ramped volume control mode. Because our limit is the volume waveform, even if our compliance is decreased, you'll still get the same ramped shape in the flow time graph because that's maintained by the limit valve. The pressure will start with an initial, relatively large increase over the pulmonary pressure, and this is where the difference starts. The pulmonary pressure will increase more dramatically because your compliance is decreased. And because the flow is decreasing, the delta between pulmonary and circuit pressures will decrease. But because the pulmonary pressure is rising so quickly, the circuit pressure curve won't look quite as flat. Then expiration will proceed relatively normally with the circuit pressure returning to PEEP. So you've maintained the same tidal volume, and your pressures have increased just like they would have in a traditional flat volume control mode. You've also lost a little bit of the benefit of the flat shape of the pressure curve, but on the whole, you've maintained a lot of your advantages. If the same decrease in compliance were to happen in pressure-regulated volume control, on the right-hand side of the screen, you'll start with a normal breath on the pressure graph, because pressure is your limit variable. And as we know, if compliance is decreased, our flows will also decrease substantially, which means a lower tidal volume. In the next step, the servo mechanism says, wait a minute, I need to deal with that by increasing pressure. So in your next breath, your limit variable is still inspiratory pressure, but the ventilator computer will have set it much higher. Your compliance is still low, so your pulmonary pressure will still increase quickly, and so your flow curve is still going to be sharp, but it's going to be higher in magnitude, so hopefully your tidal volume is hitting its goal. So that's how these two modes respond to an acute decrease in pulmonary compliance. Now let's look at how they behave if the patient coughs during a breath. One more time, we'll start in ramped volume control on the flow time graph. Because flow is the limit variable, that graph will always look about the same. On the pressure graph, the breath begins as normal with a rise in circuit pressure to drive flow, and then things get interesting when the pulmonary pressure bumps up because the patient coughs. Because this is a flow-limited mode, the circuit pressure also follows parallel to the pulmonary pressure increase, and then expiration proceeds as normal. So we've had a higher peak pressure, but no change in our ventilation. Now let's see what happens in pressure-regulated volume control. Since this breath is pressure limited, we start up on the pressure time graph, draw out our inspiration. As the patient coughs, this causes the delta between pulmonary pressure and circuit pressure to decrease, which means decreased flows and a decreased tidal volume. On the next breath, the ventilator computer is going to increase the inspiratory pressure to try to increase the tidal volume. It can't tell the difference between a transient cough and a more permanent decrease in compliance, and that can result in too high an inspiratory pressure and too big a tidal volume on the next breath. Of course, in one more breath this would be corrected, and there are in these modes always upper limits on how much inspiratory pressure the ventilator will apply. Now I draw all this out not because it's important to think, what if the patient coughs every time you put one on a ventilator, but because thinking about these different scenarios can help you understand your ventilator modes in general a little bit better. To wrap up, let's look at one last technique for getting the best of both the pressure control and volume control modes. This one is called volume assured pressure support. And as the support word in its name suggests, this is an interactive mode with patient-triggered breaths, but we'll focus here on how it responds to compliance changes. This is fundamentally a pressure-limited mode, so we can draw a pressure control breath to look at how it acts at baseline. Now, what happens if compliance decreases? In volume-assured pressure support, the ventilator actively monitors the flow rate of any given breath, and in this breath, the ventilator computer realizes that the flow rate has decreased too quickly and will in real time switch from a pressure limited breath to a flow limited breath during this one breath. So that means the first half of the breath will look like a pressure control breath with constant pressure and decreasing flow, but then if the flow decreases too much, the second half of the breath will look like volume control with constant volume flow and an increasing pressure. I'm showing you this mode not because it's particularly common in the hospital, but just to demonstrate one more way that a ventilator can try to get the best of both in terms of a pressure control shaped breath with a guaranteed tidal volume. So to summarize, this time we looked at 3 strategies to combine the best features of pressure control mode and volume control mode. Those were ramped volume control, pressure-regulated volume control, which is a servo mode and changes its pressure limit to hit a target tidal volume, and volume-assured pressure support, which switches from a pressure limit to a volume limit if it's not going to reach its target tidal volume on any given breath. We looked at how these modes react to compliance changes to build some intuition about how they work, and next time we're ready to look at interactive ventilator modes with patient-triggered breaths. Thanks so much for your attention. I'll see you next time.